5725, initials KW. She had implants from 1997 through the armpit, the axilla. These are 20-year-old set of implants, the saline implants she got. She had a capsular contracture grade 3 on the right, capsular contracture grade 4 on the left, and you can see it's like a nice big round ball. Same thing over here on the right side with the R. It's a nice round ball. I removed some of this tissue. It's very inflamed, irritated, angry. She has what are 330 textured saline implants. So what I'm going to do now is I'm going to go ahead and remove this tissue. As you can see, it's not healthy tissue. That's why I incorporated this tissue along with the capsular tissue, because this is not healthy. And so this is going to be a little bit tricky because she has textured implants. They're like super glued. So what I'm going to do is I'm going to actually go here. I just want to show this area. This was right on top at the lower level. We can disregard that. So this is the tissue that you have. I'm going to go in from here. This is, as you can see, this is the capsular tissue, but the tissue around. So this is the take-home message with this Facebook Live. This tissue that I have around does not look healthy, as you can see. This is abnormal, inflamed, angry, irritated, and this tissue needs to go as much as the tissue that is the capsular tissue. So I'm going to go in from here. Again, I just want to go slow. I don't want to hurt this implant. As you will see, this is very tightly adherent. Let me go in from here. So En Bloc, the gold standard. The section was very tedious, very inflamed tissue. This looks like a good entry point right here. A lot of inflammation that was removed along with the implant. So as I go in over here, and you can see it's textured. It's like literally adheres to the tissues, soft tissues. I'm going to go ahead and get a so you can see as I go in, super tight. Remember, it's a capsular contracture. Blood loss was like 2 cc's, if at all, this side. And as I cut in, you'll see it just literally is tightly adherent to the tissue. Here's the valve area. So I'm going to go ahead and, I don't want to pull on it, otherwise it might leak. Here's the valve. Actually, I can cut this. It's sealed. So, textured implant, I'm going to go ahead and remove this. And so look, there is some fluid, all contained. And you can see, look how thin the capsular tissue is. So this is your 330 McGann, just like the patient said, it's overfilled. And you can see if I put the ruler here, you can read right through it. Very thin capsule. All of this capsular tissue has been removed. There were some calcifications noted. You can see in here the snaps. And all of this capsular burden has been removed. Now the other thing I want to show here with this overfilled McGann implant, if I go like this, there's fluid. Not enough to send to cytology, but this, none of this spilled into the chest. And overall, I'm very happy how everything went. So you can see it's very slippery, slime type of a consistency. So I'm going to go ahead and remove my top glove now. We're going to send some of those cultures shortly for aerobic, anaerobic, and fungal. So I have my sterile gloves on the left side. I cut a lot more skin. She had a grade 4 capsular contracture. And I'll tell you, if I go like this, it's rock hard solid. And the poor lady had this on her chest for all these years. So again, I would just want to highlight this tissue over here is not healthy, and that's why it was removed. So as you can see, look at this, how it looks, and it has a nice shell to it. You don't want to leave this behind, this tissue, because from my experience, this has the foamy macrophages. This has, from the pathology reports that I've seen. Now I'm just going to go ahead and try to find like a nice, so this is hard like a rock right here. You can see the calcifications. I'm actually going to try to go in from here, and we'll see. And again, it is literally, I am having a hard time gripping it. Now there's a chance that I may injure or hurt this implant. I'm going to try to go in from here, from this side. Again, all of this tissue has to go. In my practice, I remove it. We don't want to take any chances. We want to give the patient the best chance for recovery. Remember, there was a lot of inflammation around the implant. I'm going to go ahead and go in from here. Very ultra tight. Come in here. I'm going to dissect this out and find kind of like a, you can see this tissue does not look healthy. Let me go in from here. Remember, this is like super tight, and there's areas of calcification here. This is a softer area, so I feel that I'll be able to enter. And you can imagine how tight this is as I cut through. This was painful, that's why it was a grade 4. That's the difference between a 4 and a 3. So let me go in, actually, or here. So as you can see, I'm having a hard time even gripping. Let's see. Let me try it here. Try a different pickup here with the teeth. So people ask, is it harder? No, for me it gets easier as I dissect, because this is a hard shell that I have to dissect against versus a thinner capsule. But the amount of inflammation is so significant, that's what adds to the challenge of the case. And you have to remove all the bad, leaving behind good tissue, and that certainly adds overall to the complexity of the case. I go in, let me go in from here. As I remove this, you will see why it's getting more, it's more involved, because it is so hard and so tightly adherent. There is no, so let's see what happens here. Again, I don't want to hurt my saline implant. This is an intact implant. Saline implants, when they do rupture, they rupture completely. Here you go. So you see this creamy discharge, it's part of this calcification. So now what I'm going to do is I'm actually just going to use my fingers to do the dissection. I have to be very careful because there are calcifications here. And I don't want to hurt myself. I'm just going to peel this off. And I'll cut right here. You can see it's like the scales of a fish right here. So you can see, look how tight this is. Just removing this, you can imagine, is a task. So you can imagine the surgery in itself. All bad tissues removed completely, and literally you will see how this patient was living with this hard shell on her chest. And these were supposed to be the nicer, better, safer gummy bear, the 1997 saline implants. The gummy bears had not been released, and you can imagine yesterday's Facebook Live, there was nothing gummy about that implant. So as I removed this, literally a very hard shell, it's so tightly adherent, and you can imagine why I chose to be away from this area. And just dissecting this out is proving to be a challenge, as you can see. So here you go. Literally, you can see. I'm actually going to cut this. You see this band? Literally, it's like a saucer right here. And as you will see, I'm going to invert it. Look at this. You want to leave this behind? Absolutely not. All of this needs to be removed, and as you will see, hard. You can only imagine how relieved the patient's going to be. The patient came all the way from Massachusetts. It's one of the highest concentration of the best hospitals of the world. So hard, and look at this intact McGann 330 textured saline implant. So there you have it. En Bloc, the gold standard, complete total capsule removal, implant removal, plus that inflamed tissue around. The body in itself does a very good job protecting it, be it a ruptured appendix or in this case, this inflamed tissue. And the implant was encased with a nice shell, but appears to be calcified. So the implants will be returned to the patient, the overfilled saline implants, and I'll tell you the way they are overfilled, it is not recommended by the manufacturer because it puts undue stress on the walls of that saline implant. The saline implants will be returned to the patient. Capsules to be sent to pathology. Rule out the BIALCL CD30 analysis. Rule out BIALCL CD30 analysis. Rule out lymphoma. Rule out malignancy. Rule out breast cancer. Cultures for aerobic, anaerobic, and fungal. And most importantly, we'll see how the patient does post-op minus these toxins. This is Dr. Khan, Executive Plastic Surgery.